This video is brought to you by Global Men's Wellness, your 24/7 AI health expert. No copays, waiting rooms, or awkward conversations. Just real answers whenever you need them. Visit globalmenswellness.com to try it free and get your own on-demand concierge-level wellness expert today.
Welcome back to the 21st Century Man podcast. We're doing something a bit different today, kicking off a series where we take a deep dive into chapters from the 21st Century Man, a book you, our listener, shared with us.
That's right. And first up is Chapter 90, Prostate Health, a really vital topic.
Absolutely. It's an organ that, well, it plays a big role, but can also cause significant health issues, especially as men age.
It really can. And the chapter starts with a powerful quote from General Norman Schwarzkopf.
It does. I'm living proof that if you catch prostate cancer early, it can be reduced to a temporary inconvenience and you can go back to a normal life. Really sets the stage.
It underscores the whole point, doesn't it? Our mission here is to, unpack this chapter, highlight the key facts, explain some of the terms, and pull out those actionable things you can actually use.
Okay, let's jump right in then.
Yeah.
The basics. What exactly is the prostate?
Well, fundamentally, it's a gland. In younger guys, it's about the size of a walnut, sits right below the bladder.
And its job?
Its main job is making fluid about 20% of the seminal fluid, the liquid that helps carry sperm.
It's part of a larger system, though, right?
Exactly. You've got the seminal vesicles, which make another big chunk of the fluid, and the vas deferens, tubes that bring the sperm down from the testicles. They all kind of meet up in that area.
The source mentions it's usually 20, 30 millimeters across in younger men.
Yeah.
What controls its growth?
Mostly testosterone, and its more potent form, DHT. They act on receptors in the prostate. And this is important later when we talk about prostate issues.
Okay.
And the whole gland is wrapped in this thin, tough membrane called the capsule.
All right, let's unpack the first big issue the chapter tackles. Benign prostate enlargement, BPE or BPH. Benign meaning non-cancerous.
Right. And the numbers here are, well, pretty staggering. The source makes it clear this isn't some rare thing.
How common?
50% of men by age 50 have some enlargement causing symptoms. 60% by 60, 70% by 70, and get this, 80% by age 80. It's almost, a standard part of male aging.
Wow. That really reframes it. Not some unusual problem, but something most men will face. And the core issue is its location.
Precisely. The urethra, the tube carrying urine out from the bladder, it runs straight through the middle of the prostate. The chapter uses a great analogy. Think of the prostate like an apple. You're trying to pee through the space where the core was. As the flesh of the apple grows, it squeezes that channel.
And that squeezing leads to all those classic urinary symptoms we hear about.
Exactly. You get what are called obstructive symptoms because the flow is blocked. So a slow stream, trouble getting started, what we call hesitancy, the stream stopping and starting.
That feeling like you haven't quite finished.
Right. Urine retention, difficulty fully emptying the bladder. And then there are irritative symptoms because the bladder is working harder. Things like needing to go more often, that sudden strong urge, or waking up multiple times at night.
The chapter mentions sphincter muscles, too.
Yeah.
How does the prostate affect those?
Well, you have an internal automatic sphincter and an external one you control. But with BPH, the main problem is the blockage itself, downstream from those sphincters. The enlarged prostate obstructs the flow out, regardless of sphincter function, causing those emptying issues and triggering the bladder irritation.
And if you don't treat BPH, it's not just inconvenient. It can cause actual problems.
It can, yes. The source mentions potential complications like urinary tract infections, bladder stones forming from that leftover urine, and even, over time in severe cases, kidney damage.
Yeah, and here's a really crucial takeaway the source emphasizes. Treating an enlarged prostate early will help you avoid more involved surgeries later on. Surgeries that can have significant negative side effects.
That's a huge point. Being proactive isn't just about feeling better now, it's about potentially avoiding much bigger issues and more invasive treatments down the road.
Okay, so what about prevention or lifestyle approaches? Does the source mention anything that can help manage these BPH symptoms?
It looks at a few things. Herbal therapies are quite popular, but the source offers some clarity here. A big review of saw palmetto didn't show a difference compared to placebo.
Really? That's probably the most well-known one.
It is. So that finding kind of debunks a common belief. Now, beta-sitosterol and Pygium africanum, they do have some studies supporting them, but the source notes they're generally not considered as effective as current prescription meds.
What about Kegel exercises? You hear about those for pelvic floor health?
Right. The source clarifies they don't stop the prostate from growing, but they can help with controlling urinary leakage, which is sometimes an associated issue, though separate from the enlargement itself.
Interesting. And there's a connection mentioned to gut health.
Yes, this is a really interesting sort of emerging area. The research highlighted suggests our gut microbiome, the bacteria in our gut, can influence inflammation throughout the body, potentially including the prostate.
How so?
Well, this inflammation might play a role in things like prostatitis, chronic pelvic pain, BPH, and maybe even prostate cancer outcomes. So the thinking is reducing things like sugars, high carbs, junk food that helps your gut, and might indirectly benefit your prostate by reducing that inflammation.
Feed your gut. Feed your prostate. Interesting. Now, what about things to avoid? The source points fingers at some common over-the-counter meds.
Yes, this is a really practical, important point. Certain everyday medications can actually make urinary symptoms worse or even cause retention where you can't pee at all.
Like what?
Antihistamines, decongestants, think common cold, cough, and allergy meds. Things like Benadryl or Sudafed are specifically mentioned as examples.
Wow.
Yeah. The advice is to be cautious and always check the label for warnings about difficulty urinating if you have prostate issues.
That's definitely good to know. Something you take for a sniffle could mess with your plumbing.
Mhm.
So if lifestyle tweaks and avoiding those meds aren't enough, what are the go-to medical treatments for BPH?
According to the source, the first line is usually a class of drugs called alpha blockers.
Okay, how do they work?
They basically relax the smooth muscle tissue within the prostate gland and at the bladder neck. Think of it as loosening the grip around that urinary tube.
Examples.
Drugs like terazosin, doxazosin, tamsulosin, silodosin, brand name Rapaflo is mentioned.
Do these actually shrink the prostate?
No, that's key. They just relax things to improve flow. The source does note some, like terazosin and doxazosin, aren't specific just to the prostate and can also lower blood pressure.
Ah, so that's why taking them at bedtime is sometimes recommended.
Exactly, to help manage potential dizziness or fatigue. The more prostate-specific ones, like tamsulosin and silodosin, have less effect on blood pressure, but have a higher chance of causing retrograde ejaculation, sometimes called dry ejaculation.
Okay. Then there are the 5-alpha reductase inhibitors.
Right, these work differently. Finasteride, dutasteride, those are the names. They actually do shrink the prostate.
Yeah.
Usually by about 20%, but it takes time, maybe 6 months or so. And they have a quirky side effect you need to know about if you're getting PSA tests.
Which is?
They artificially cut your PSA blood level reading by about half. So your actual PSA is roughly double what the test shows. Important context.
And these are also used for hair loss, right? Propecia.
Finasteride is, yes. A potential downside mentioned for these drugs is possibly decreased libido for some men.
All right. What about tackling those annoying irritative symptoms? The frequency, the urgency.
For those, sometimes anticholinergic medications are used. Colchicine, Detrol, sulfasenacin, Vesicare are examples. But the source gives a pretty strong warning about one called oxybutynin or ditropan,
Why?
because it can cross the blood-brain barrier and potentially cause cognitive issues like fogginess or memory problems, especially in older men.
Is there a better option mentioned?
Yes, Myrbetriq is highlighted as working well for urgency and frequency without those cognitive side effects. It can be more expensive, though, which sometimes limits its use.
And a caution with these bladder-relaxing drugs.
A crucial point. Because they relax the bladder muscle, if you already have a significant blockage from BPH, they could potentially make it harder to empty your bladder fully or even cause retention. So you need a proper evaluation before starting them.
Can doctors prescribe these different types together? Like an alpha blocker and one of the shrinking drugs?
Absolutely. For guys with more severe symptoms, combination therapy using both types is quite common.
And the source mentions Cialis, the erectile dysfunction drug.
Yes. This is a great point highlighted. Tadalafil, which is Cialis, specifically the 5 milligram daily dose, is actually FDA approved for treating BPH urinary symptoms.
No, a 2-for-1 benefit potentially.
Exactly. It can help improve urine flow and erectile function for men dealing with both issues.
Okay, so medications are often the first step. But what if they're not enough, or symptoms are really severe? What's next?
That's when you start talking about procedures or surgeries. But, and this is a huge but in the source, before you even think about choosing a procedure, you absolutely need imaging.
Imaging? Like what kind?
Yes. A transrectal or transabdominal ultrasound looking closely at the prostate and bladder is essential. Maybe a cystoscopy where they look inside with a small camera, possibly even a prostate MRI. The source is emphatic. Do not proceed without this information.
Why so crucial?
Because the best procedure for you depends entirely on the specifics, your prostate size, shape, the type of symptoms you're having, and your goals regarding sexual function. It has to be individualized.
Makes total sense. Know what you're fixing before you try to fix it.
Mm-hmm.
So once you have that imaging, what procedures are highlighted maybe for smaller prostates?
For prostates generally under about 60 cubic centimeters, the chapter recommends considering either Rezūm or UroLift.
Tell me about Rezūm.
Rezūm is usually done in the office, often with some sedation. It uses sterile water vapor, basically steam, injected into the prostate tissue via a scope.
Steam.
Yeah. It causes the targeted tissue to die off and be reabsorbed over time. A big plus is there's no permanent implant left behind. It's quick, not much bleeding.
Downsides.
Well, symptoms actually get worse for the first week or two because of swelling. And the full benefit takes a few months to really kick in. The source mentions a temporary spanner stent might be used for comfort during that initial phase.
Okay. And UroLift. How's that different?
UroLift is also minimally invasive, often outpatient. Instead of destroying tissue, it uses tiny, staple-like implants to physically pull back the enlarged prostate lobes that are compressing the urethra. It's like holding curtains open.
And the results?
Often immediate improvement in flow. Big advantages are no tissue removal, usually no need for a catheter afterward, and this is significant for many men. It typically has no negative impact on ejaculation.
Any limitations?
Yes, it's generally best for certain prostate shapes and sizes, so that pre-procedure ultrasound is key to see if you're a good candidate. You might have some temporary frequency or urgency for a few weeks afterward as things settle.
What about the sort of more traditional surgeries?
Things like TURP, transurethral resection of the prostate, and its newer variations like bipolar TURP, green light laser, plasma vaporization, or even enucleation procedures are discussed. These are done in surgery centers and involve removing or vaporizing prostate tissue.
How do you choose between those?
Often depends on the surgeon's experience and the specific prostate anatomy. These procedures are effective, but as the source notes, they commonly cause significant changes to ejaculation. Often little or no fluid comes out. Effects on erections are usually mild, though.
And if the prostate is really large, too big for these transurethral approaches?
For very large glands requiring what's called a simple prostatectomy, removing the inner part of the prostate, the source makes a very strong recommendation. Get it done robotically.
Right. Using the Da Vinci robot.
Yes, ideally by a surgeon who does a lot of them. The recovery and outcomes, according to the source, are far superior compared to the old-fashioned open surgery or even TURP for these very large prostates.
Okay, that covers BPH treatments pretty thoroughly. Let's pivot now to the other major topic in this chapter, prostate cancer. Often the bigger fear for many men.
It is, and the statistics provided really highlight why it's such a significant health issue, even though the story isn't always grim.
What are the numbers?
Well, in the U.S., it's the most common cancer in men if you exclude basic skin cancers, particularly over 50. Globally, it's the second most commonly diagnosed cancer in men overall, about 1.3 million new cases a year worldwide.
And in the U.S.?
Around 190,000 new diagnoses annually. It's the third leading cancer diagnosis for American men.
What's the lifetime risk of getting diagnosed?
In the U.S., it's about 12%. But, and this is a really crucial insight from the source, many prostate cancers are very slow growing. The majority of men diagnosed will actually die of something else entirely before the prostate cancer becomes a serious problem.
How do we know that?
Autopsy studies are fascinating. They find evidence of prostate cancer in about 30% of men in their 50s and up to 70% of men in their 70s who died from other causes and never even knew they had it.
But it can be fatal. It's still a leading cause of cancer death.
It is. It's the fifth leading cause of cancer death for men worldwide and the second leading cause for U.S. men. About 33,000 deaths a year in the U.S. So the lifetime risk of actually dying from it in the U.S. is much lower than the diagnosis risk, around 2.4%. That distinction is important.
And unlike BPH, which causes those urinary symptoms, early prostate cancer often has no symptoms at all.
That's the major challenge for early detection, yes. It's usually silent until it's much more advanced.
Who's considered at higher risk, according to the source?
Several groups. Men with a strong family history, especially a father or brother diagnosed young. Men carrying certain genetic mutations like BRCA1 or BRCA2. And African American men who unfortunately have both higher rates and more aggressive disease.
And PSA testing comes in here because it can pick things up early.
Potentially, yes. The source notes that PSA levels can start to rise 5, 10, even more years before any clinical signs or symptoms appear.
Okay, let's talk PSA, prostate-specific antigen. What is it?
It's a protein made by the prostate gland cells secreted into the semen. A tiny amount normally leaks into the bloodstream, and that's what we measure. It's used as a marker, not perfect, but a marker to help screen for cancer, monitor treatment, and check if it comes back.
What's a normal PSA level? Does it change?
It does tend to increase slightly with age, and the source really emphasizes using age-adjusted cutoffs for what's considered abnormal.
What are those cutoffs?
Generally over 2.5 for men under 50, over 3.5 between 50 and 60, over 4.5 from 60 to 70, and over 6.5 for men over 70. Though it notes some doctors still just use a single cutoff, like 4, for everyone.
When should men start thinking about PSA testing?
For those high-risk groups, African American men, or men with that close family history under age 65, the recommendation is to consider baseline testing starting in their 40s. For others, it's presented as a shared decision between you and your doctor. You need to understand the pros and cons. Screening isn't generally advised over 70 unless someone's in really excellent health.
Okay, and then there's this thing called percent-free PSA. Why is that important if your total PSA is high?
This is crucial. PSA travels in the blood either attached to proteins or floating free, unbound. The percentage of that PSA that's free gives you valuable information.
How so?
Basically, a lower percentage of free PSA suggests a higher chance that the elevated total PSA is due to cancer, rather than just BPH or inflammation.
Are there specific percentages to know?
Yes. The source gives guidelines. If your percent-free PSA is less than 10%, the chance of cancer is considered high. Over 50% chance is mentioned. A biopsy would likely be recommended. Between 10 and 25%, it's more of an intermediate zone. Biopsy might be considered. But if it's over 25%, the chance of cancer is low, less than 10%.
So knowing your percent-free PSA before jumping to a biopsy seems like a key takeaway.
Absolutely. It helps differentiate. An enlarged prostate can definitely raise your total PSA, but the free PSA percentage, along with imaging like MRI, helps sort out whether it's likely benign or something more concerning.
Good tip. Any other PSA pointers?
Yes. Always repeat an initial abnormal PSA test to confirm it wasn't just a lab blip or temporary issue. Also context. PSA under 1 is usually normal in younger men. Cancer rarely spreads if PSA is under 25. Widespread disease often means PSA in the hundreds or thousands.
Okay, beyond the blood test, what else? The digital rectal exam, the DRE, still has a role.
It does. It might not be anyone's favorite exam, but the source makes a strong case that it's still important. It allows the doctor to feel the prostate size, check for hard spots or nodules that could suggest cancer, and also check for infection or even unrelated issues like anal cancers.
And it can find cancers missed by PSA.
Critically, yes. Studies cited show cancer being found in up to 18% of men who had a normal PSA level but an abnormal finding on their DRE. So it adds information.
It sounds like PSA isn't foolproof then. Can it be falsely elevated?
Definitely. And knowing these causes is important. Things like a urinary tract infection or prostatitis can raise PSA. Recent urologic procedures, even the DRE itself, can cause a small and temporary bump.
Anything else?
Yes, and this is interesting perineal trauma. That means things like recent ejaculation or even prolonged intense bicycling can temporarily raise PSA. The advice: avoid ejaculation and strenuous cycling for 48 hours before your blood draw.
Good to know.
And don't forget those 5-alpha reductase inhibitor drugs we talked about for BPH and hair loss, finasteride, dutasteride. They artificially cut the PSA reading in half. Your doctor needs to know if you're taking them.
Okay, that's helpful context for interpreting results. What about imaging specifically for cancer detection? You mentioned MRI earlier for procedures.
Yes, this is where technology has really advanced things, according to the source. Multiparametric MRI, or MPMRI, ideally on a stronger 3 Tesla magnet rather than a 1.5 T, is proving very useful.
How so?
It's much better at visualizing suspicious areas within the prostate, especially in the front part of the gland, which standard biopsies often miss. It's increasingly being used before a biopsy is even considered, especially if PSA is elevated.
And it can help guide the biopsy itself.
Exactly. That's called MRI ultrasound fusion biopsy. They overlay the detailed MRI map onto the live ultrasound image during the biopsy procedure. This allows the urologist to precisely target the needles into those specific suspicious spots seen on the MRI, rather than just taking random samples.
Was it more accurate?
The data suggests yes. The source cites results showing these targeted biopsies are significantly better at finding clinically significant cancers, the ones that actually need treatment, compared to the old standard 12-core random biopsy method.
There was a specific study mentioned.
Yes, comparing MRI plus targeted biopsy versus the standard approach, it showed something like a 57% improvement in detecting significant cancers, used 77% fewer biopsy cores on average, and led to about a third fewer unnecessary biopsies overall.
That's a pretty compelling difference.
Yeah.
Seems like the way forward.
The source strongly suggests so. The quote is something like, "I believe that a pre-biopsy MRI will eventually become standard protocol." The idea is it helps find the dangerous cancers earlier and helps avoid biopsies altogether for many men whose elevated PSA might be from benign causes. MRIs are also valuable for staging, seeing if cancer has spread, and for monitoring during active surveillance.
Okay, so let's say cancer is diagnosed. How is the initial treatment path decided? Sounds like a lot goes into it.
It's definitely a multifaceted decision. The source lists the key inputs, the PSA level, of course, the Gleason score, which grades how aggressive the cancer cells look under the microscope, any specific molecular characteristics found from testing the biopsy tissue, how far the cancer appears to have spread based on that MRI, and maybe other scans like bone or CT scans, and then very importantly, your overall health and age.
And the patient's own priorities must factor in.
Absolutely essential. Your personal tolerance for potential side effects, particularly the risk of changes to erectile function or urinary control, has to be part of the discussion. The source also recommends looking into molecular tests on the biopsy sample. Names like Oncotype DX, Polaris, Decipher are mentioned, and considering genetic screening for mutations like ATM or BRCA, which can indicate a more aggressive cancer.
So lots of information gathering. What are the main treatment options discussed?
Well, for many men diagnosed with low risk or even some intermediate risk prostate cancers, the trend is increasingly towards active surveillance.
What does that actually mean?
It means actively monitoring the cancer rather than immediately treating it. This leverages the fact that so many prostate cancers grow very slowly. It typically involves regular PSA checks, periodic MRIs, and repeat biopsies, maybe every few years.
And the benefit.
The huge benefit is avoiding or delaying the potential side effects of treatment incontinence, erectile dysfunction, unless or until the cancer shows signs of progressing or becoming more aggressive.
But if active treatment is needed or chosen, what's the surgical recommendation?
Robotic prostatectomy is presented as the best surgical approach currently available. And the source gives a really practical tip here. Find a surgeon who does a lot of these. High volume, ideally more than 100 cases a year using the Da Vinci robot.
And it's okay to ask about their results.
Absolutely. You should feel comfortable asking about their specific outcomes, particularly the rates of preserving continence and erectile function.
What about radiation?
Radiation therapy uses high-energy beams to kill cancer cells. The source contrasts older methods, which might involve 40 treatments over 8-10 weeks, with newer, highly focused techniques like CyberKnife, which can deliver a full course of treatment in just 1 week with potentially similar outcomes.
Are there even newer approaches focused on minimizing side effects?
Yes, the chapter highlights that focus. HIFU, high-intensity focused ultrasound, recently got FDA approval in the U.S., and it mentions MRI-guided focal laser therapy, which is showing promise in treating specific, targeted areas of cancer within the prostate, potentially curing selected cancers without the common side effects.
Wow, okay. This chapter is packed with so much vital information. Let's try to boil it down. What are the absolute key takeaways the source wants men to remember?
I think the big picture is understanding that the prostate can cause issues, but there are effective ways to manage BPH and diagnose and treat cancer, especially with modern tools. Working with a good urologist is key.
The source actually lists specific takeaways. First, on PSA testing frequency.
Right. Check it every other year between 50 and 75. But if you're high-risk African American or that strong family history before age 65, start considering it by age 40 and maybe more often. And always, it's a shared decision with your doctor.
Second, about BPH symptoms.
They're super common and usually very treatable with medications. And treating early helps avoid those bigger surgeries with more side effects later. That's a big one.
And Cialis.
That Cialis 5 milligram daily dose can help both urinary symptoms and erections, worth knowing.
If you get a new prostate cancer diagnosis.
Make sure you discuss genetic testing options and definitely get a second opinion on your treatment choices before you commit to anything.
And finally, probably the most cutting-edge takeaway, if you have an elevated PSA.
Yes. Get a prostate MRI before any biopsy. And if a biopsy is needed, push for an MRI-guided fusion biopsy, not just the old standard random one. That seems to be the modern standard of care emerging.
Those are incredibly clear, actionable points. It really strikes me how well the 21st Century Man presents this complex information.
It really does. It manages to be comprehensive and detailed, but also clear, practical, and frankly empowering for men navigating these health issues. It makes complex medicine accessible.
We definitely encourage you, the listener, to read the full book if you can. This deep dive gives you the highlights, but the full chapter provides so much valuable context and detail.
Absolutely. It's a worthwhile read for understanding your own health.
Well, that wraps up our first deep dive, focusing on Chapter 90, Prostate Health from the 21st Century Man. Thanks again to our listener for sharing this fantastic resource.
It's a topic that touches so many lives, and clear information like this is just invaluable.
It really underscores how quickly things are changing in men's health diagnostics and treatments. It kind of leaves you thinking that staying informed, being proactive, and having these conversations with your doctor, even if they feel awkward, is more critical than ever.
Couldn't agree more. The potential for better outcomes keeps growing.
Join us next time on the 21st Century Man podcast as we continue through the book with our next deep dive into Chapter 91, Peyronie's disease.
We'll look forward to exploring that one with you.
Take control of your health anytime, anywhere. Visit globalmenswellness.com and start your free trial today. Get expert-level answers in seconds, not weeks, without the cost, the wait, or the awkward conversations. Real support on your terms. Visit globalmenswellness.com now.